like to welcome you to the latest in our Cameroon CamDoc webinar series. And our webinar today will be on diabetes, all you need to know. We have three very august speakers with us who will be talking to you about different aspects of diabetes care and diabetes management. And we hope it's going to be a very informative session for you. So after each talk, we will have a few minutes for some questions, but please do put any questions you have in the Q&A box, not the chat, the Q&A box. So we will tackle them as we go along, but also after all three talks, we will have a panel discussion. So any questions which are not answered straight after the talks will be discussed during the panel discussion. So my name is John Ayuk. I'm one of the endocrine consultants at University Hospital Birmingham, and I'm moderating the session today. As I've said, any questions you have, there will be a chance to discuss some after immediately after the talks, and also later during the panel discussion. But please do put them in the Q&A so we can distribute them to the appropriate speaker. One more thing to mention is at the end of the session, there will be a survey which will be put in the chat. So please do take time to participate in that for us. It's just to help us improve and make these things better. So without much ado, I will introduce our first speaker, who is Dr. Helmine Kejem. She's a consultant in general internal medicine, endocrinology, and diabetes at Liverpool University Hospital's NHS Foundation Trust here in the UK. And she's going to be talking about new therapies for type 2 diabetes management.
Hello, I'm Dr. Helmine Kejem. I'm a consultant physician, diabetologist and endocrinologist at Liverpool University Hospitals. Thank you, CamDoc, for organizing this session about something that I'm passionate about. So we're going to talk about new medications in type 2 diabetes, but we're going to dive into what diabetes is and the different types of diabetes. So diabetes, as we know, it's a pandemic affecting everywhere in the world, but unfortunately, Blacks are more affected, both in Africa and in the diaspora. And it's a chronic disease. It doesn't just happen one day. It happens as a result of when your blood sugar levels is persistently high for a long period of time. And we know that blood goes to every part of your body, and blood goes through vessels, which I would say pipes, to different parts of your body. So hence diabetes can affect every part of your body, from your eyes to your heart, if any of the pipes get blocked, to your brain, which will cause a stroke if any of those pipes block, to your kidneys, which can at some point end you on dialysis. It supplies blood to your legs as well. So if that is not happening, then you're at risk of having infections and amputation. So it's very, very important. Hence the reason why I think this webinar will be very helpful for those that are not diabetic, for those that are diabetic, to know that they need good blood sugar control. Now, during the talk, we'll be talking about the types of diabetes, and my focus will be more on type 2 diabetes, the old medications and the new medications. Right, so diabetes, there are many types of diabetes, but we're going to focus on three main types. So type 1, which is when your body cannot produce any insulin at all. Hence, you're going to need insulin from when you're diagnosed to the end. And how that happens is that you've got some chemicals in your body that is destroying your pancreas, and your pancreas produces insulin. Insulin is the chemical that helps to bring your blood sugar down. And the second type of diabetes I'll talk about is gestational diabetes, which is diabetes that young women have when they are pregnant. And that's because your body cannot handle high blood sugar during pregnancy. What that tells us is that you're at high risk of developing type 2 diabetes. So I advocate, and I say, and we say it all the time, is that if you've had gestational diabetes, every year you need to have a test for diabetes. That if there is anyone on the webinar that has ever had gestational diabetes, please talk to your doctor and have a test for type 2 diabetes. And every year you need to do that. Type 2 diabetes is what we're going to talk about today. It can happen two main ways at which it can happen. It can be that your body is not producing insulin, which you need to bring down your blood sugars. So it's just saying, my pancreas is lazy, I cannot produce it. Or is that your body is producing the insulin, but also your body is not responding to it, which we say you're resistant. You're not sensitive to it. You're resisting insulin. It's there, but you're not sensing it. And it's very common in people that are overweight or obese. Um, Now, like we said, it doesn't just happen. Usually it can go on, you don't have any symptoms. But once you start feeling very thirsty, drinking a lot of water, eating as much, going to the toilet, especially in the middle of the night, weighing too much, some people would have weight loss, your vision goes, you start having loads and loads of infection upon infection. Because in as much as we love sugar, bacteria and fungi, they love sugar too. So you have recurrent infections as a result of that. Now, at this point, you've gone to your doctor. Am I diabetic or am I not diabetic? So in the UK, and I think in general, although our figures might be different, they can test whether you have diabetes in, well, four main ways: HbA1c, your fasting blood sugar, your random blood sugar, or your oral glucose tolerance test. What is commonly used in the UK is your HbA1c, which is, it tells us what your blood sugar has been in the last 3 months. So if you've got sickle cell disease, or you're requiring recurrent blood transfusion, or you're on dialysis, this would not be representative. So your doctor would need to look for other tests to be able to test you to know that whether you're diabetic or not. Now, if your HbA1c is less than 42 millimoles, which is 6%, well, it means that things are okay, but just keep working on yourself. If it's between 42 and 46, what it means is that you're a ticking time bomb. You need to look after yourself, weight loss, try and be very active. And also at that range, I would advise that you should continue to do your yearly HbA1c just to make sure that you've not slipped over and you've become diabetic. Now, if your HbA1c is greater than 48 or greater than 6.5, it means that you're diabetic, but you need two readings, 3 months apart. If it's still greater than 48, then you'll be classified as a diabetic. And it's still the first line for management of diabetes is lifestyle change and lifestyle change, lifestyle change. The doctor will start you on metformin, which is usually, it's commonly prescribed everywhere. That's the first line. If you don't tolerate the standard metformin, because you have to start at the lower dose, 500, and then you increase your dose as you can tolerate. If you cannot, tolerate metformin, the normal standard one, then your doctor can prescribe a modified release metformin for you. But from when you're diagnosed, it's important that you at least do your HbA1c every 3 months, and that you have your eyes checked every year, and that you have your urine checked to make sure that your kidney is not beginning to leak proteins. And it's important that you look after your feet as a woman will look after her face. So you have to be very, very careful. Now, if metformin doesn't work and your HbA1c stays at 48 or increases to 58, they can add common agents that they can use are glycoside, which is a sulfonylurea, or they can add plergitazone. Now, if it's staying greater than 58, then they can now think about triple therapy. Hence our talk. But the other thing, once you're diagnosed, is that your GP needs to calculate, or your doctor needs to calculate your risk of having heart attacks, strokes, problems with your blood vessel, because that would tell us what other medications to add to your treatment. Then comes these are the older medications, metformin, glycoside, sitagliptin. But then comes the newer ones. I'm sure everybody has heard about Ozempic. Actors, everyone is using it. What it is it's called a glucagon-like receptor agonist. This injectable, where you inject once a week, which is the Ozempic. There are other types, Saxenda and all of that. Or there is oral semaglutide that you can have, and you can have it once a day. Usually you start with small doses and you build it up gradually as you can tolerate it. And how does it work? Basically, all that the scientists have intelligently thought about is they've made a medication that would copy one of the chemicals that you produce when you eat. But now that chemical, if you're not on this medication, lasts only for 1 to 2 minutes. But once you're on this medication, it lasts for longer. How that helps is that it just prevents food from your digestive system to slow down. It prevents food from going from your stomach to your intestines quickly. So you feel really full, and you don't feel like eating too much. You eat very little quantities. And the side effect of that is that most times, one of the common side effects is that people just feel sick. They feel like they're going to be sick. So nausea and vomiting, and also abdominal pain as well. Also, it just works in your brain and you feel full and you don't have appetite. All of that, in summary, what happens is that you're not eating too much and your body becomes more sensitive to insulin. And so you lose weight, your blood sugar control becomes better, your blood pressure improves. And as time is going on, in as much as there are side effects to Ozempic, there are also some benefits. But then we don't know a lot about it because it's really a new medication that is in block. So coming back to us, so if you've been on 3 medication, it's not working, in the UK, the doctor will think about, oh, is it time for you to go on insulin, or is it time for you to go on a GLP-1 agonist? Now, who can go on it? The NICE guidelines, so the guidelines in this country, it's quite clear. If your BMI, which is your body mass index, if it's greater than 35, but remember, if you're black, you need to take away 2.5 from it. So if your body mass index is greater than 32.5, and say, for example, you're struggling with very bad arthritis, you're struggling with sleep apnea, or psychologically you're really depressed and you cannot go out, and everything all related to obesity, then your doctor can prescribe that for you. If you're under 32.5, but going on insulin will be very difficult for you. Say, for example, you're driving long distances, you're working in places that are not hygienic, where you cannot inject or check your blood sugars, you can advocate for yourself to have it. And also, if you're under 32.5, but you're having complications, very bad arthritis at a young age, sleep apnea, yes, you can. Who cannot have it? If you've got type 1 diabetes, you cannot have it. If you're pregnant or breastfeeding, you cannot have it. If you're preparing for pregnancy, there's a caveat that you need to stop at least 1 month before you get pregnant. So, and if you're allergic to it, you cannot have it as well. If you've had a particular kind of cancers, absolutely no. If you've previously had some acid in your blood, which we call ketoacidosis, no. The other thing that I just need to mention is that because it slows down your digestive system, if you're going to go for surgery, even if you're buying it privately, please tell the anesthetist, because you're at high risk of reflux if you don't stop it a couple of weeks or months before. And the next one, so the benefits, it's great in improving your blood sugar control. As an endocrinologist and diabetologist, it's great that someone would not have low blood sugars, so what we call hyperglycemia, even when they've got to an HbA1c of 48. It's what we're looking forward to. The weight loss, the fact that you're reducing your risk of strokes and heart attacks, makes Ozempic a very good medication for people with type 2 diabetes and obesity. The newest kit in the block, which is amazing because it has two functions, is tirzepatide, which is marketed as Mounjaro. It's similar to Ozempic, but this time around it's more potent. It will cause more weight loss and more improvement in your blood sugar level, and some improvement in your fat levels as well. But then the side effects are still similar, but sometimes in some patients worse. Now, the other medication, which is really useful, especially if you have risk of heart attack, strokes, kidney problems, is what we call sodium glucose transporter 2 inhibitors, SGLT2 inhibitors. There are not a number in the market, but the most commonest one we use is dapagliflozin. How it works is basically that it just prevents your kidney from absorbing sugar. So literally you're weighing sugar. And as you're weighing sugar, water is coming out with the sugar that is coming out. So if you've got heart failure with diabetes, that's very helpful. If your kidneys are struggling with diabetes, that helps to get rid of the water. And it's been found to have a lot of benefit. And so protects people from having heart attacks, protect people that have had heart attack from it getting worse, protect people's kidney from getting worse as well. It's quite good. It's a very, very good medication. However, when the studies were done, there were not a lot of black patients in the study that shows all of this benefit. So we're using it in black people, but we actually don't know if we'll get this level of benefit. So why I'm bringing this talk out is if you're somewhere and they're doing clinical trials, it's a good idea to enroll because it might not help you, but it might help your next generation. So it's good to enroll in trials. Um, so because wherever sugar is, bugs would grow, your risk of urinary tract infections, your risk of having dehydration because of course you're losing a lot of fluid, a lot of water through your urine. So we always advise that you drink a lot of water to stay hydrated. If you are unwell, so you're having diarrhea, vomiting, which are sicknesses that will make you lose water, you need to stop that medication because it might make you really unwell. Now, who cannot have it? So if you've got if you've got a previous bladder cancer, if you've had bladder cancer or treated for bladder cancer, your doctor shouldn't. If you've had acid in your blood before, your doctor shouldn't give you that. And it's important if you're on this medication to obey the sick day rule. If you're unwell, not even if you're not having diarrhea or vomiting, just stop it for a few days until you're better to restart the medication. Thank you very much. Any questions?
Thank you very much for that, Helmine, for that whirlwind tour of the basics of diabetes and the management, focusing on the newer medications. So in the Q&A, there are a few questions, if you don't mind. I'll start by asking you the first one, Dr. Helmine, can a patient with diabetes go into remission? So can they get rid of the diabetes? And if you've got a diabetes patient on insulin, can they ever come off it?
It's a very good question because there are lots of trials going on in the UK at the moment, and where in I think Newcastle, where people that were diagnosed within the first 2 years of diagnosis and that had significant weight loss went on a low carb diet and lost weight, went into remission. So we would say you're in remission if you're off medications for 3 months and your HbA1c is less than 48, then we will say you've gone into remission.
Okay, thank you.
Yeah, and
Oops.
the other question about can you come off insulin? Yes, because if, say, for example, you've not been, unfortunately, not been checking to find out from your doctor to see if you have diabetes or not, and all of a sudden you start having symptoms and you come into the hospital very thirsty, um, you know, um, dehydrated, unwell, we will start you on insulin until you get better and until your blood sugar level comes down. And then we can now stop the insulin and continue you on oral medication and while we are monitoring you every 3 months to see what your HbA1c is doing. So yes, you can come off. So you can use it in the interim when someone is unwell. And you can use it as well when you're trying to bridge where someone is trying to do lifestyle changes as well. And so once the control is better, then you can start reviewing the medications again. And some people have lost a lot of weight and have done really well and have come off insulin.
Okay. So someone wants to know, is Mounjaro safe? So many are using it for weight loss.
So it's a very good question because we don't have long-term data for it, safety data for it. A lot of people that are using it for weight loss purposes, yes, they've got other side effects of nausea, vomiting. Some people can have abdominal pain, pancreatitis. The long-term effects, we don't really know. One of the side effects that they did say which was found in rats, was that it was people were at risk of having medullary thyroid cancer. Hence, that's why if you've got any medullary thyroid cancer, you're advised not to go on Mounjaro. And if you've had pancreatitis before, because it works on your pancreas as well, not to have it. Otherwise, if you don't have any contraindication, yes, you can have it. Is there a long-term side effect? We don't know. Time will tell. But if you must have it, if you must have Mounjaro, just be aware that we don't know what the long-term side
Okay.
effect is.
So there's a question about whether these drugs are available in Cameroon, but in fact, we have speakers from Cameroon coming on soon, so I won't ask you that one. Can you explain a bit more about pre-diabetes for people with sickle or sickle cell traits? Some common routines to prevent diabetes without medication? So two parts to that question. There's a sickle cell bit. Is there any link?
Well, I think the link is basically for you wouldn't, if you have sickle cell trait or if you have sickle cell, you wouldn't use HbA1c for diagnosis because it wouldn't be reliable. Because HbA1c would monitor what your blood sugar has been in the last 3 months, and what it uses is the life cycle of a red blood cell, which is 90 days. So if you are your trait or you are or sickle cell disease where your blood cells are the changing really quickly, that would not be reliable for you. So you probably will benefit from a fasting blood sugar, glucose, or oral glucose tolerance test than HbA1c.
And some common routines to prevent diabetes without medication?
I think it's diet and lifestyle, isn't it? So low carbohydrate diet is what we advocate for, not meaning that you wouldn't eat carbs at all, but that you limit it, and that you're exercising, starting with basic works during the week, at least 150 minutes of walks would really, really add up. So every little helps. So walking, exercising, any little thing that you can do to keep moving will go a long way. Just remembering that from our ancestors, one of the reasons why more blacks have diabetes is it's more of looking at our ancestral root, that our great grandfathers never had loads of food as we've got now, and they used to walk to the farms, and um, they were always active. So it all comes back to us. Let's look backwards and see what people were doing years and years before that. The incidence of diabetes was not that high, and think about it now. What are we doing different and trying to copy them?
Another question. You mentioned trials. How do we know which one is safe to enroll in? You're on mute, by the way.
Well, I think, well, I'll talk about the UK. I think most trials in the UK are safe. Um, I know we're all always very paranoid about that they're going to use our data, they're going to use us. If you go and they're doing a drug trial, you might not even know what arm you are in. You might, because usually they might say, okay, the treatment arm will be this and the non-treatment arm will be this. So if you're worried, just read about it. You can ask anybody in CamDoc, if you're in the UK, send it across. We can have a look and then we can like advise. But I would really, really, really advocate for people to enroll in trials. It's very important
Thank you, Helmine.
because we need data from our community. We're using most of these drugs, and even the Ozempic and the Mounjaro, we were not represented in that data, but we are using it with very,
Okay.
very little information about what's gonna happen for us. So if you get into a clinic and and if you're worried, I'm happy if you can contact me to just go through it. I can tell you if yes or no. But yeah, it's one of the things I'm pleading for our community to get involved.
Thank you, Helmine. So our next speaker is Mr. Takwe Boniface Njecko, who's a program manager for NCD prevention and control program, the Cameroon Baptist Convention Health Services. And he is going to be telling us today about diabetes prevention and patient challenges, bridging and how we bridge the gap for better care. So, Mr. Takwe, please.
Thank you so much for this opportunity. I am Takwe Boniface, and that's my profession working with the Cameroon Baptist Convention Services with about 15 years of practice as a nurse in NCD prevention, which includes diabetes. I'm excited today to share one of the strategies that the CBC Health Services is using to prevent NCDs, which includes diabetes, which is called the Know Your Numbers strategy, which has helped a lot to many people to prevent diabetes. And I will also be talking a bit about some of the prevention strategies and the challenges that people living with diabetes may face in caregiving, and also how we can bridge some of these gaps. My colleague, Dr. Helmine, has already described what diabetes is, which is a chronic disease because of poor usage of insulin and glucose in the body. And she's mentioned the three major types of diabetes. We have type 1 diabetes, which is more common in the younger age group. Type 2 diabetes, which occurs more in the elderly population, but now occurring frequently in the younger age groups because of many of them developing diabetes. And we also have gestational diabetes, which is already mentioned. Diabetes, when not well managed, can produce a lot of harm in the body and can affect so many systems. It can affect the nerves, can affect the eyes to lead to blindness or any other condition, it can affect the heart, can affect the kidneys, and sometimes even lead to amputations, and why not even impotence. And so because of these challenges that diabetes produces, it becomes very important for us to prevent it. And so the CBC created the NCD Prevention and Control Program, which has two major components, the Know Your Numbers component and the diabetes and hypertension component. And the Know Your Numbers component is very important in that it's being run by well-trained nurses who assess apparently healthy individuals, those not living with diabetes, high blood, cancer, asthma, or any of the NCDs. These people are screened to see if their health numbers are in order, and they're screened for high blood pressure. They are screened to check their body mass index, screened for their waist circumference, since an elevated waist circumference increases disease risk, especially diabetes, and their blood sugar numbers are also checked. And after this screening, they are given counsel depending on the abnormality that has been seen. And if some of their numbers have been seen to be grossly out of order, they are either referred, they may be referred to the doctor for a confirmation of the diagnosis, where they will later on be referred either to the diabetes and hypertension unit or to whichever unit, depending on what has been seen. You can see what is happening now. In 1990, this is how we were. Look at the TVs. In 2008, look at where we are now and what have our TVs have become. Where do you and I separate ourselves? Just look at it. And so, apart from assessing the vital health numbers of individuals, NCDs have been identified to have shared risk factors. And WHO has already said if these shared risk factors are adequately managed, those that should be avoided, and those that we need to do, we do those things, about 70% of NCDs can be prevented. And so, after assessing the vital numbers of an individual, his drinking patterns are assessed, his feeding patterns are also assessed, tobacco use is also assessed, his exercise patterns are assessed, and also exposure to indoor air pollution. These are all things that can increase someone's risk to develop NCDs, which includes diabetes. And after this assessment, the individual receives counsel or is referred, depending on what has been identified. Now, people are also being encouraged to prevent gestational diabetes, which my elder has already said something about it there. And for us to adequately prevent gestational diabetes, it becomes very important for us to identify which are some of those groups that have a high risk to develop gestational diabetes. As earlier mentioned, anybody who in a previous pregnancy developed gestational diabetes should be handled with care. Anybody who has developed impaired glucose tolerance in the past, or someone with pre-diabetic blood sugar values, especially the female here, in the non-pregnant state, that is having blood sugar values of between 100 to 125, you are a suspect and need adequate care. Or somebody coming from a background where there is a family history of diabetes, especially in first-degree relatives. Or somebody who is becoming pregnant with a pre-pregnancy BMI of 30 kilograms per meter square and above, or becoming pregnant at an age of 35 years and above, or somebody who in her previous deliveries gave birth to a child weighing 4,000 grams and above. These individuals are at high risk
It looks like we have a problem with our link again.
Nutrition before, during, and even after pregnancy. And we encourage people to try to attain healthy weight gain during pregnancy. Most women do not know that there is an average amount of weight that you're supposed to gain during pregnancy. We also educate mothers who give birth to low birth weight children, children weighing less than 2.5 kilograms, or those who give birth to high birth weight children. These mothers need education on how to care for these children as they grow in an attempt to reduce their risk of developing obesity and diabetes and the other incidents that can follow. And so mothers are also being encouraged to practice exclusive breastfeeding for at least 6 months. And so what type of breastfeeding have you been practicing? Our mothers are also being encouraged to aim to return to their pre-pregnancy weight by 6 to 12 months, because if weight loss doesn't occur, it can increase the risk to develop gestational diabetes. Now, in a situation where somebody doesn't succeed to prevent the diabetes and it develops, some of these people may encounter some challenges while seeking health care during the time that they are living with the diabetes. And what are some of these challenges? Sometimes some of them have a limitation of disease knowledge, not knowing some of the complications that can occur during the disease process, or how the disease process can bring about a change in the way they feel. And so we are encouraging people living with diabetes to regularly join support groups, because when they join this group, they will share their experiences with others, and others will share with them. And from this, they can learn from this experience and know how to avoid some of these complications. We also encourage people living with diabetes to ask questions when with a healthcare provider who will give them good answers on how to mitigate some of these challenges. Some people living with diabetes also encounter the difficulties of breaks in drug administration, and some find it difficult to modify their lifestyle. What are some of those things that can cause people to have breaks in drug administration? Some people may forget to take their drugs, and because of this, we encourage them to inform their reliable family members who can remind them to take their drugs. Some may stop taking their drugs, sometimes because of side effects. And instead of stopping, we encourage these people that once you start taking a drug and you experience some uncomfortable feelings, go back to your healthcare provider who will give you instructions on how to manage this situation. Some may find it difficult, good places to store their insulin, especially when they are not in their normal comfort zones. And so the insulin may now get bad. And so what you may be administering may no longer be the active insulin. This can now cause a challenge, because what you're administering is no longer the drug, so it can be considered as a break in drug administration, because what you're administering is no longer the drug. Some of them may even go to some occasions, and because they don't want people to know the condition they are living with, they will be looking for places to hide and administer the drug. And if they don't find suitable places where they can hide to take the drug, they may miss, drug doses may be missed. And so this again can bring about breaks in drug administration. And some people may find it difficult to adjust their lifestyles. Like sometimes they may find it difficult to implement the dietary patterns that have been instructed to them by their healthcare provider, carry on the regular exercises as have been instructed by the healthcare provider. And this can bring a challenge to them. And so we're encouraging people that once you have a challenge, when you get to the healthcare provider, ask these questions, and your healthcare provider will give you good education on what to do to counter some of these challenges. And if your healthcare provider maybe tells you to eat some kinds of things, check and see, are these things available in the place where I live? Can I afford? If you can't afford, if they are not available, tell your healthcare provider, who will now assess what you have, assess your cultural patterns, and will know what instructions to give you on how to overcome these challenges. Some people may also have the challenge of having some emotional difficulties and psychological challenges. And some of these emotional and psychological challenges may come because of the fear of stigma. Like people will say, I'm living with diabetes. And because of this, some may start isolating themselves. They no longer want to go into groups with other people, and so social isolation may occur. And we explain to some of these people to express their worries each time that with a healthcare provider who will know exactly what kind of education to give to them. Some people may be afraid, they may have the fear of guilt, and this guilt can lead to what poor lifestyles and so on. Some may be hiding their condition from other family members. How can I make people know that it's like this? I'm sure that people may misinterpret it for hiding to take their insulin, that maybe they're taking contraceptives. And so this may cause them, maybe you are when you're trying to administer the drug, somebody may open the door and see you, and you now have psychological torture. What can people now be interpreting me to be doing inside here, and so on. And so this can be a problem to them. And so we are encouraging people living with diabetes to accept their condition, because no one ever went to the market to buy a condition and so on. And so when you accept your condition and you follow your care provider's advice, is going to enable you to live well with that condition. And so sometimes when people go for care provision, they may spend longer hours in the hospital. And so when that happens, they may not have enough money to buy drugs and so on, and that may be very, very challenging to them. And that may be very, very challenging to them. And so because of much time wasted in the hospital, financial challenges may occur, and this may cause some of the people now to stop going to the healthcare facility because they may not have money to pay for lab fees, to buy the drugs and so on. And so we're encouraging people to prepare to sacrifice at least one day a month for the sake of their health. And also sharing your disease condition with trusted family members can cause some of them to sympathize and give you financial assistance when need be. And in conclusion, we're encouraging people that prevention of diabetes along the life course is important and has been advocated for by the World Health Organization and other international bodies. The know your number strategy is one of the best strategies that can be used to prevent diabetes, as this has already been implemented in 17 health facilities in 5 regions of Cameroon. And a presentation has been done on this in Mozambique and in Tanzania, which was well acclaimed. And so why not practice this in your health facility to help the population, especially in resource-limited facilities? We are also encouraging our parents, especially those who give birth to low birth weight children and those with high birth weight children, to seek medical advice from the healthcare provider on how they can care for these children, since they have a high risk to develop obesity, diabetes, and other NCDs. And of course, healthy lifestyles will help you to reduce the diabetes risk and so on. And regularly checking of your health numbers at the health facility is very, very important to you to reduce your risk of developing diabetes. And remember, a healthy weight before and during and after pregnancy is very, very important. After delivery, fight to lose that weight. And disease knowledge by the clients and even the family and the care providers is also very important. So if you lack knowledge about these conditions, contact your healthcare provider and ask this question, and your healthcare provider will tell you what to do to manage this condition appropriately, and either to prevent the diabetes or other NCDs from developing, or to have it well managed. And that's why there are truths that when you ignore, which can help you to prevent diabetes, a whole generation can suffer, not you alone. These truths on what you can do to prevent diabetes and other NCDs, don't ignore them, because if you ignore, a whole generation risks suffering. Thank you so much for listening to me share these important facts and these strategies for us to help prevent diabetes. Thank you so much.
Thank you, Mr. Takwe. Thank you so much. I mean, I really enjoyed that, and I think all of our panelists and the audience did as well, as I can see from some of the comments coming through. So if we just, in the next few minutes, tackle some of the questions. So one question was, so I live in Douala, Cameroon. What medication for type 2 diabetes would you recommend that is readily available in the Cameroon market?
Yeah, there are quite a good number of medications that are available in the Cameroon market. You know, one of the drugs that we have used a lot for all this time, we've been using metformin a lot. There are other new drugs that are into the market, and our clinicians know best what drugs. And one of the things which is there is your clinician, after assessing your condition, will know what drug to prescribe to you. It will be difficult for me to prescribe that this is the best drug that you should take, because I don't know what other conditions that you may be living with. And so to tell you that go to the market and buy this may be an error. I would rather leave it to their clinician who will assess, because there may be a drug that is good for client A to use, but this drug may not be applicable to client B, depending on how his other organs are functioning. Therefore, the drug for you to take that will best help you will be best determined by the clinician who is doing it.
No, thank you. So next, Mr. Takwe, I'm really enjoying your talk. Are there any trials in Cameroon regarding diabetic drugs or any aspects of diabetes? So
concerning drug trials, to the best of my knowledge, I'm not aware. But sometimes there are some persons that may be carrying on some drug trials, but sometimes you won't go to the entire community or the whole entire nation to announce that I'm carrying out a drug trial on this and so on. Sometimes somebody may just sponsor you to do that, and you just look for a comfortable place where you can have the people that can be involved in it and you carry on that particular activity. So to the best of my knowledge, I'm not aware of that as of now.
Thank you. And awesome job, Mr. Takwe. How is this all funded?
Not getting you?
Sorry, so someone said you did an awesome job, like I said. And
Yes.
but they're asking, presumably, talking about this disease, the disease treatment and prevention and all of that. The question is, how is it all funded in Cameroon?
How is what I'm doing being funded in Cameroon?
Yes, yes.
Yeah, it's basically the organization for which I work, the CBC, that is funding this. And sometimes we've had some assistance. I remember sometimes ago we worked with the Novartis Business Access. They funded us and we were able to establish this Law and Numbers program very, very greatly. But after that, we didn't continue working with them, and we are looking forward to other things happening. And some other groups have also assisted us periodically, just like the World Obesity Federation just assisted us of recent, and we're able to do something during this World Obesity Day and so on. Some other groups like Save Lives and the World Diabetes Federation, they have assisted us periodically to buy some equipment to carry out some of these activities. And if we had the means, we'll really do more. We'll expand this activity to all the 10 regions of Cameroon, where most of our the 8 regions of Cameroon where our health facilities are located.
Okay, thank you. And one last question, which I think really, comes to the heart of everything we do and are trying to do. And someone asks, what happens when people can't afford medication?
When somebody can't afford medication, it becomes very, very challenging. 1, to the individual, 2, to the family, 3, to the community, and so on. And so if you can't afford medication, the condition, the disease merely just does what it does best. And that is just target those organs that it can target and do whatever thing that it can do. And so in that situation now, it becomes a burden to you, the individual and the family. And that is one of the reasons why we're encouraging people, those not living with this condition, to take all the necessary preventive measures so that this condition doesn't develop. And to those already living with it, to follow the doctor's advice effectively so that complications don't develop, because when complications develop, their pill burden increases. And as it increases, expenditures also increase, which at some point may be very, very difficult for you to be able to afford. And that can start bringing about this process of breaks in drug administration.
Thank you very much for that. And once again, thank you for your really lovely and animated talk. So we'll come to our third talk today, and this will be delivered by Dr. Anne Boli, who is a consultant endocrinologist and diabetologist at Yaoundé Central Hospital, an assistant lecturer at the FHS, the University of Bamenda in Cameroon. And Dr. Boli is going to be telling us about diabetes management in Cameroon, the past, the present, and the future. So, Dr. Boli.
Hello, good evening. Good evening, everyone. Thank you, Dr. Ayuk, for this kind introduction. I'm Dr. Boli Anne. I'm an endocrinologist working at the Yaoundé Central Hospital. So it's an honor for me to be invited to this webinar where I'm going to talk about diabetes management in Cameroon. I'll start by stating that I have no financial disclosures to make. And I'll present a few slides using this outline. I'll talk a little about the past, more of the present, and I'll give some perspectives for the future. Diabetes is a global pandemic. It affects all the parts of the world. But Africa carries the greatest burden because studies and perspectives are showing that by 2045, we're going to have more than 100% increase in terms of the number of people who live with diabetes. And precisely to talk about Cameroon, we have about 600,000 adults who suffer from the disease who live with diabetes. So how is diabetes management organized in the country? We have the Ministry of Health that has its National Non-Communicable Disease Program. And this NCD program has drawn a strategic plan which is being implemented at the level of the periphery. That's at the operational level in the district hospitals and within the diabetes clinics. In the past, we didn't have a lot of information about diabetes, the impact of diabetes in our country, until there was this study, the CamDocUK project, that was carried out in 2003 that provided scientific evidence on the prevalence of diabetes, the prevention of diabetes, risk factors of diabetes in our setting, and the presence or the distribution of healthcare services we had in the country at the time. So this is a project that enabled us to have more diabetes clinics. It helped to train personnel, healthcare personnel, and it also provided simplified guidelines for the management of diabetes at the level of health districts and at the level of health centers. So who are all those involved in the management of diabetes in Cameroon? We have the state, we have some funding bodies such as the World Diabetes Foundation and Novo Nordisk. We have both medical and paramedical staff working both in the public and in the private sectors. We also have patient support groups. We have some insurance companies, and we have research centers. Diabetes is diagnosed in the country using blood samples. So we can have blood collected from the veins or during screening campaigns collected at the level of the fingers. And diabetes is monitored using glucometers and urinalysis. That is what we had in the past. Now we have glycated hemoglobin that is regularly used. And we also have a few patients who now have continuous glucose monitoring systems, which are more effective, but expensive. So we don't have a lot of patients using this for now. But the advantage with the continuous glucose monitoring systems is that once they are applied to the body, the patient does not need to prick himself to monitor his blood glucose for about 2 weeks. That's 14 days. The cost of diabetes care in Cameroon is borne by the patient for now. So what did we have as drugs in the past? We had the World Health Organization list of essential medication, which provided or recommended the use of metformin, sulfonylureas such as glibenclamide, and regular human insulin. Those are the 3 drug classes we had. In addition to this, we've always had a considerable use of phytotherapy. And this can be understood given our context, our tradition, our culture. We use a lot of phytotherapy, either alone or in association with the medical treatment. Now we have more drug classes that are available. We have insulin analogs. We have other oral hypoglycemic agents which are available, such as DPP-4 inhibitors. We also have fixed dose combinations, that's association of 2 or even combination of 3 oral hypoglycemic agents. And the advantage of this is that it improves compliance of the patients because they have less tablets to take daily. There are other interesting drug classes which are still expensive in our context, such as SGLT2 inhibitors and GLP-1 receptor agonists. I won't get into the details because Dr. Mbene has already done that. So the monthly direct cost of diabetes in Cameroon was estimated at 92,755 francs CFA by a study conducted by Mapa Tasu in 2019. And this cost, this direct medical cost involves the drug, buying the drug, consultation fees, laboratory tests, hospitalization. It is just an average. And there I've put a picture of the main types of insulin which are available in the country. And their cost ranges from about 6,000 francs CFA to 9,000 francs CFA. There are also indirect costs of diabetes, which the patient can incur. We have transport for patients who have to travel from one town to the other to meet their specialists. We have feeding, carer needs, housing for those who have to displace themselves, and the loss of productivity. Once a patient with diabetes becomes disabled, the chances of him losing his job or his source of income increases. It's worth noting to note that we now have a lot of progress has been made. We now have more trained specialists. We have a program which is dedicated to the management of children with type 1 diabetes. We carry out holistic management of the diabetes patient. That is, we don't focus on bringing down the blood sugar. We also take care of the other problems, medical conditions the patient can have, and we make sure that we reduce the risk of him having cardiovascular complications. And we have a lot more diabetes clinics and diabetes reference centers. Talking about the distribution of these specialists on the national territory, I didn't have a number, fixed number of specialists. It's not yet known, but right now there is mapping that is ongoing by the ministry to know so that we can know the geographic spread across the country. Most of the specialists, the diabetologists, are now located or work in Douala and Yaoundé in the main towns. We have others in Mara, Garoua, Yaoundé, Limbe, Konsamba, just to name a few. And in towns where you don't have diabetologists, you have internists and general practitioners who take care of patients with diabetes. I mentioned that we now have national reference centers for the management of diabetes. And I'm going to take the case of the National Obesity Center in Yaoundé. It was created in 2001, and it became, since 2006, a clinical investigation center. That is a center where studies are being carried out to better understand what causes diabetes and what can improve the management of patients who live with diabetes. At the time, it had only 3 specialists. But now in 2025, it has greatly improved and it has become a multidisciplinary center with national and international references. We have 5 endocrinologists, we have internists, we have nephrologists on seat who take care of the patients who have complications. We have a nutritionist, we have a pharmacy, we have a podiatry service, we have an endocrinology unit, and a unit which is specific to patients presenting with foot ulcers. Talking about the Changing Diabetes in Children program, I said it's a special program which is funded by the World Diabetes Foundation in partnership with other bodies like Novo Nordisk. And its main aim is to improve the condition of children who live with type 1 diabetes in low and middle income countries. In Cameroon, it was launched in 2010, and we already have 11 clinics in 8 regions in Cameroon, and about 1,300 children are already enrolled. So most of these children come presenting with complaints of frequent urination and thirst, and there are other symptoms as well. There are also activities, health promotion activities, which are ongoing in the country. I'll take the example of this large study which was conducted by the RSD Institute with the aim of teaching children in secondary schools what healthy eating habits are, what a balanced diet is, and why it is important to practice regular physical activity. You've probably heard about the universal health coverage, which is ongoing in Cameroon. The first phase was launched in 2023. Right now, it doesn't take care of patients with diabetes. All what we benefit from now is preventive and promotional health activities and reduced cost of hemodialysis sessions for patients who have diabetes and chronic kidney disease. So talking about perspectives, we hope for subvention. We need subvention for the management of comorbidities because most patients with diabetes have 2/3 of them suffer from hypertension as well. Others have other diseases such as gout, obesity, heart failure. Hospitalization facilities and podiatry equipment are also required for patients with diabetic foot ulcers. We also need annual laboratory tests and cardiac evaluation and subvention for glucometers and strips. We have many patients who find it difficult to buy glucometers, and it's difficult to keep patients on insulin and other medications without monitoring. We also we need to have improved access for insulin analogs and oral hypoglycemic agents. These are examples of new drugs which are available in the country, but which are still very expensive. We need a community-based approach. We've talked about that already in the previous presentations, insisting on prevention. We don't have enough money, we don't have finances to manage complications of diabetes. So we need to work on improved therapeutic education and improve public health policies to encourage people to have healthy diets, regular physical activity, to fight sedentary lifestyle, smoking, alcohol, and alcohol consumption, and to increase the number of screening campaigns. More research, and to develop and sustain projects such as the Changing Diabetes in Children project, to train more specialists, podiatrists, and paramedical staff. And we also advocate for more regulation to establish strong regulations on the use of pharmaceutical products. I'll take the example of semaglutide, which is already suffering, which is being famous because of unauthorized use in our country. So to conclude, Diabetes, a lot has been done about diabetes management in Cameroon. We have improved so much, but we need greater commitment of stakeholders of the healthcare chain, the state healthcare personnel, the civil society, patient support groups as well, all this to improve diabetes management and to reduce complications of the disease in our country. I cannot end the presentation without acknowledging my mentors who have been visionary and dedicated leaders. And I'll invite all the endocrinologists and diabetologists who are not yet registered to register in our society so that we improve and we fight against diabetes, we improve the management of patients suffering from diabetes in our setting. Thank you for your kind attention.
Thank you so much for that talk, Dr. Boli. So again, let's have a look at some of these questions. So there's one question which asks if these drugs are available in Cameroon. This was an earlier question when Dr. Helmine was doing her talk about the the SGLTs and the GLP-1s and all of that. So maybe you could help us answer that, Dr. Boli?
Sorry, I didn't get you, Dr. Ayuk.
So the question is, the drugs Dr. Helmine Kejem was talking about, like the GLP-1 agonists and the SGLT drugs, are those drugs available in Cameroon?
Yes, doctor, these drugs are available in Cameroon. I put the slide on new medications, which are expensive but available. We have more SGLT2 inhibitors, which are available in most of the public pharmacies. And I don't know much about the private hospitals, but we have them in most of the public pharmacies. We also have a few pharmacies which who provide GLP-1 receptor agonists, such as Ozempic. But the cost of a container, a box, is over 100,000. And one pen is meant to be used for a month, that you have 4 doses for a month. So the patient has to spend on average about 130,000 francs each month.
Okay. And another question, are there no incentives for anti-diabetic drugs in Cameroon?
No subventions, nothing. There is a patient who pays for his medications.
Okay. And another question. When my dad had breathing difficulties, he went to the hospital and was prescribed a drug that he could not find in the pharmacies. The second time the condition happened, it led to his death. Please, are these drugs actually available in Cameroon? I think we've sort of answered that, but maybe if you want to...
Come again, please. I didn't get the question.
So the question is, so one of our audience members is saying, when my dad had breathing difficulties, he went to the hospital and was prescribed a drug he could not find in the pharmacies. The second time the condition happened, it led to his death. So the question again is, how do people get hold of these drugs? Are they actually available in Cameroon? And okay. I think you've partly explained, yes.
Yes, I've explained, and I don't know in this case if the drug that was requested or was prescribed was an oral anti-diabetic drug or another drug, but it happens sometimes that we have rupture of the supply chain of one medication or the other. Unfortunately, it does happen.
All right. And another question, how much does a Freestyle Libre cost in Cameroon? Is it easily available if one can afford it?
Not all pharmacies supply Freestyle Libre, not all. And the last time I checked, it was over 50,000. There are some particular pharmacies from where you can order.
Okay. And another one, Dr. Boli, following up from the previous question, what is the most cost-effective diabetic medication to use in Cameroon for your patients? A lot of people feel drugs in Cameroon may not be as effective. What is your experience of this?
Okay. the most cost-effective drug to be used, I
Yes.
would say, is the combination of a biguanide, what we call metformin, and a sulfonylurea. Like there are many sulfonylureas we presented. We talked about glimepiride, glyclizide. But it's important to say that the recommendations of the American Diabetes Association and other international societies is that we have to we decide on which drug to prescribe with respect to the individual's condition. You may have two patients with type 2 diabetes who have the same age, who are in the same family, but who will not have the same prescription because of the other comorbidities they have, that is the complications they are presenting with, their past history. One who already has diabetes, hypertension, is different from another one who does not have, even if they have the same age. If one is already presenting with cardiac complications of diabetes, that's if the patient is told that he already has his coronary arteries, his blood vessels in the heart that are blocked, then he's going to have a different prescription from the person who does not have that. If one is already having kidney disease, be it linked to diabetes or not, he's not going to receive the same diabetes drugs as like the other person who does not have. So in terms of price, they are the two drugs that I've given because they have shown they are old drugs which have proven to be very effective, and they are relatively affordable for our context. Those are the two drugs. Now, for those who can afford, we go in for the other drugs, that is to align with the 2025 recommendations. That's using the GLP-1 receptor agonist, the SGLT2, or the DPP-4 inhibitors.
Okay, and the second part to that question was, a lot of people feel the drugs in Cameroon may not be as effective. And I know that's the common theme in many developing countries where people feel the drugs which are exported to developing countries are not as effective as, the same drug when it's being used in, in Europe or United States. Is this something you've come across in your experience as a prescriber?
Most of these drugs I use are effective in the patient. What I advise the person to do is to get his drugs from the pharmacy, not from the roadside, or because sometimes there are drugs which are not well preserved, which may lose their efficacy. But most of the drugs that I've used, be it specialties or generics, are effective.
Okay. Thank you very much, Dr. Boli. There's still some questions, and I think now would be, we can go back and have a general discussion around, we can go through these questions. If you want to pick some out from the Q&A and answer them in writing, then that's fine. But I thought we could use some of these questions just to sort of trigger the general panel discussion. So there was a question from Mr. Takwe talking about, are there any cases of your patients going into remission? So that might be something which, Mr. Takwe, if you want to start answering, but I think our other two panelists would be able to contribute to that as well.
Yeah, I may just indicate here that the people that we've seen have noticed gone into remission are people who were identified with pre-diabetic blood sugar values, where the fasting blood sugar value ranges between 100 and 125. Some of them who were living with a big body build. And so when they fought and they lost weight, most of these blood sugar values were now corrected. But as for those who were outrightly on drugs, not, they are also to use this to say, I know these are some of the challenges that we are facing, and God has helped us. We now have an obesity doctor stationed in one of our hospitals in Douala, who is now able to do bariatric surgery. That is at Mamfe Baptist Hospital. And so this is a situation where if somebody is living with diabetes as a result of obesity, this person or somebody living now with morbid obesity, which can lead to some of these, they can benefit from the services of this surgeon who is at Mamfe Baptist Hospital.
Okay, thank you very much. And Dr. Kejem, Dr. Boli, have you guys got any thing to add?
Yeah, Dr. Ayuk, thanks. I would like to add something about remission. I think it's a concept we have to be very careful with in our context. We're in a context where in Africa and in Cameroon in particular, about 90 or 80% of the patients living with diabetes are not diagnosed. So we still have a lot of work to do about screening, about diagnosing and following up. And we also have a lot of issues with compliance. Many patients stop coming to the hospital once their blood sugar values improve. So it's a concept that's personal, is not a recommendation, but I really try or I avoid talking about it because the patients will okay, once they get better, they'll just stay off their medications, saying to themselves, okay, this might be remission, I no longer need to, because some even come, there are lots of follow up, and when they come back to us, they tell us they thought they were already fine, they didn't need to, they didn't require to take the medication throughout. And so we still have a lot of work to do about therapeutic education and to let them understand that it's a chronic disease. Thank you.
Okay, thank you. Helmine, anything to add?
Yeah, I think I would agree with Dr. Boli that remission concept on African, wherever, is a difficult concept that should actually be discussed with a lot of caution, in the sense that even if that's why they have said you're in remission doesn't mean you're cured. So it's kind of actually making us understand that its remission is not a cure. And there is a lot of hard work to stay in remission. And it's not just stopping and not doing your HbA1c. Again, even if you're in remission, the priority is always, or the advice is always, you're still going to do your 3-monthly or 6-monthly HbA1c forever. So it's not like, oh, go, I'm not going to see you again, bye. No. So I agree with her that it's tricky. But however, there's a push that if you're diagnosed within the first 2 years, it doesn't mean you should not go on your medication. Go on your medication, work hard. And if you go into remission, good, but know that it's not a cure, know that it can come back again. And it's just making sure that you don't miss that window where you're coming in very, very unwell, or when complications are setting in already.
Okay, thank you. The next question is, I think this one is specifically for you, Mr. Takwe. How do we subscribe to NCD programs of CBC in Cameroon? How can people who want to get involved do that?
Yeah, if somebody wants to get involved with the NCD Prevention and Control Program of Cameroon, one, it depends what kind of involvement that the person desires to have. Is he a client who just wants to benefit from maybe care provision, or is he somebody who wants to assist in some way to see how he can empower the organization to provide better care? If the person is coming from this angle where maybe he has a means somewhere and he wants to empower the organization to offer better care to the citizens, you can contact the hierarchy of the organization, the leadership of the organization. Or if you contact me and say, this is what I want to do, I can lead you, direct you to who are among the leadership persons that you can contact and start communications with.
Okay, thank you. Thank you for that. That's useful. And I hope it's useful for the person who asked. Now, okay, another interesting question. And this one is, I'd say interesting because it's something which is discussed and debated about a lot of non-communicable diseases. Are there local herbs that can help in the absence of medication? And this one, Dr. Boli, do you want to?
Yes.
To start off?
There are local herbs that can help in the absence of medication, but I'm not going to mention them here because we've not had results of clinical trials conducted that show how effective they are, that show when they can be used and how they can be used. But I acknowledge the fact, and as I said in my presentation, many of our patients use local herbs. And sometimes we've found, we even noticed that we had to take them off some medications or take them off the local herbs because combining them with the usual drugs was causing hypoglycemia, but I cannot mention them because I don't have the proofs. Okay, no study has been, clinical trials have not been conducted. We have some studies that have been conducted at the National Obesity Center with some vegetables, which showed to be effective, but we are still working on that, so I will not get into it. So they actually, some do work.
Okay, thank you. Next question is actually from one of our CamDoc members, and is aimed at Dr. Boli and Mr. Takwe. So certainly in the UK and in I know across Europe and the Americas, for various medical conditions, there are patient support groups which do a lot to advocate for patients, for treatments, for people who have those conditions. Is there a patient support group for diabetes in Cameroon? Mr. Takwe, do you want to take that one?
I didn't get you because it went off. Kindly help again.
Oh, I'm sorry. So we're just asking whether you have patient support groups in Cameroon for diabetes.
Yes, exactly. We have patient support groups in all the 17 facilities which are operating the Know Your Numbers program. In all these facilities, we have diabetes and hypertension support groups where patients come on monthly basis to have their drugs refilled. The physician sees them and does what it does their drug refills and modifies their treatment if need be. So I have support groups in all these 17 facilities, and we are looking forward to increasing the number this year.
Actually, I think the question was actually more about patients themselves forming advocacy groups.
Okay, and from that angle, I'm not aware of that. But what I know is that we just have the support groups where they come to receive their drugs and they share their experiences. But from that other angle, I'm not quite aware.
Okay. Dr. Boli, any?
Yeah, in Yaoundé, we have, I know of two patient support groups, one for patients with type 1 diabetes and their parents, who work a lot, who collaborate with the Changing Diabetes in Children program, and one for patients with type 2 diabetes, which is owned or coordinated by a nurse who was working in our unit, who now has a private center in Yaoundé.
Okay, thank you. Okay, next question. Dr. Boli, a lot of people have bad experiences of their relatives with diabetes dying after what happens to be a routine admission. Any ideas why?
The first thing I would say about this is that diabetes is a silent killer. Sometimes patients get in and they seem not to be too bad or not to have a lot of problems. So when we get in the course of investigations, other complications come up. I'll take the example of a patient who came, walked out of his car, came for his appointment for his checkup, and I think about 30 minutes after his evaluation, he got back to his car, and we noticed there were a lot of people around. That was at the General Hospital in Douala. And they informed, when we came up, we noticed that the patient just had a cardiac arrest in his car. So that was somebody who was moving around, just to say that these patients come, we cannot, or the family members or the family or the patient itself cannot know all what he's suffering from. So it's important for the patient to come for regular checks. It may help us to reduce the occurrence of such complications. That's the first thing. And secondly, we have a lot of issues about insulin. Many patients don't want to be placed on insulin because they say in their neighborhood, people complain about insulin. It's like once you have diabetes and you're placed on insulin, it worsens your condition or it can cause death. Insulin comes as a replacement therapy. It comes to, we just provide what the person is lacking, as Dr. showed in her presentation. So, Dr. Bennett, so you cannot, this is not brought to bring in complications. And what causes, I think what causes death is the fact that there are a lot of underlying complications. That's the first thing. And diabetes is a disease that brings about immunodepression. It reduces the ability of the body to fight infections. So somebody who comes in with a chest infection, for example, who has diabetes, will not cope with it or will not tolerate it the way somebody who does not have diabetes would do. And that is one of the problems we had during the COVID pandemic. Those who had diabetes were at risk of having the complicated form of the infection and dying from it. So those are a few answers I can give to the question.
Okay, thank you. So there's a question earlier on about...
And sorry, Dr. Ayuk, and to scare people more, there have been trials that if you're diabetic and went on chemotherapy, you're likely to do worse than people that were not. So there were two arms, people that didn't have diabetes, chemotherapy, people that had diabetes, chemotherapy. Those that had diabetes on chemotherapy did worse. So it's just to point Dr. Boli's point that diabetes is a minefield of a lot of things. So prevention and better control is what we would really advocate for.
Okay, thank you. So there was an earlier question, Helmine, while we've got you, with someone who asking if type 2 diabetes is due to insulin resistance, how come it's treated with insulin?
I think going back to our mechanisms, there are two ways. Is one, either your pancreas is lazy or your body is lazy to produce insulin. Or two, your body is resistant to the insulin. So if you've got the type where your body is lazy to produce insulin, then you need insulin. But sometimes they can be together, so it can be both. But usually if you start requiring insulin, so basically, well, the hypothesis is that as you're accumulating fat, visceral fat, there's fat also in your pancreas that is like stopping your pancreas from working well. Mm-hmm. And so the hypothesis is that if you lose weight and you lose some of the fat in your pancreas, you might get some of the cells that will work for you. But if by the time you realize that you're diabetic, your pancreas is not working for you, then you need extra help, then you need insulin.
Okay, thank you for that. Dr. Boli, you mentioned earlier on about the availability of the GLP-1 agonists and the SGLT4 drugs and so on. So I think so, and you, someone I think would like some ballpark figures about around how much these drugs would cost in Cameroon. Are you able to provide that?
About the GLP-1 receptor agonists?
Yes, how much they would cost in Cameroon?
Yeah, we have their two forms or doses that are available. One that costs about 110,000, and another one 130,000 and 150,000.
Okay, another question.
And the SGLT2 inhibitors are cheaper. They cost about 10,000. Some may be less or a little bit more. But they are the GLP-1 receptor agonists that are very expensive.
Okay. So another question, and again, this is probably Dr. Boli and Mr. Takwe are best placed to answer this one. Are there plans for the expansion of existing diabetes services in places like Mamfe?
Is that to me?
Hello?
Both of you.
Okay.
So, Mr. Takwe, do you want to go first?
Yes, I know the CBC has a health facility in Mamfe, but one of the limitations that was had about the creation even of a lower number service there is because of space. I've been communicating with the chief of center there. He says he really sees so many patients living with diabetes, hypertension, and other diseases, but there is no space for them to operate this service. That's the difficulties that we're having there. Maybe other health facilities can do that. As of now.
Thank you. The next one is actually something in just almost in support of what you said, Dr. Boli, when you answered the question about herbs. So someone says, as a medical student and young GP in Cameroon, we were advised to completely stay away from herbs because we could not be sure of drug interactions with formal treatments such as metformin. Dr. Boli, is that what is still in place, or do you now tolerate some herbs?
Oh, yeah, that is still in place.
Yeah.
That's why
Yeah, I think
I don't want to get
answer.
into the details. Yeah, it's
Yeah.
still in place. What we can tolerate is foodstuffs. I'll take or vegetables, as I said. I'll just take the example of okra. We have some patients who come who tell us that who ask if while taking their drugs they can still continue taking their raw okra. That's a grind okra and they drink in the glass without any other addition. We don't deny that because it's like taking their okra soup with their fufu. Okay, so it's because it's like their meal. We don't stop them from doing that. But if it's taking herbs, mixing herbs and doing other things, no, it's not still allowed because remember that these patients are at high risk of developing renal complications. So we cannot, we advise against that.
Okay. Next question. Thank you so much, Dr. Boli, for the wonderful presentation. How effective is glibenclamide in treatment of hyperglycemia?
Glibenclamide is effective in the management of hyperglycemia. It reduces glycated hemoglobin like the other sulfonylureas of the same class. The problem we have with glibenclamide is that it's a first generation sulfonylurea, and the risk of the patient developing hypoglycemia is higher as compared to the newer members of the same drug class. So that's why we most of the times we advise patients to switch from glibenclamide to other sulfonylureas when they can. But there are some parts of the country, remote areas, where you don't have any other sulfonylurea available. If the patient cannot travel out, if other medications are not available, then if you check and the patient's kidney function still allows you to use glibenclamide, then you can use that in association with metformin. Remember, I said it's found in the WHO list of essential drugs, so it can still be used, but in places where you don't have another option.
Thank you very much. So we are bang on 7:30 p.m. UK time, which is when we promised to finish. And so I would like to thank all of our sort of speakers, our other panel members, the people who've been working behind the scenes, but most of all to thank our attendees, because obviously the only reason we do these webinars is for the community. And it's been really nice to see so many of the comments in the Q&A of people who have been really appreciative of this webinar and of the knowledge and insight that our speakers have brought in covering this topic. So thank you very much, everyone. And with this, I will bring, actually, the survey. Please remember to look in the chat and do the survey. But with this, I will formally bring the session to an end. Do look out for our next webinar because there will be one coming along. And, many of you out there have links to us members of CamDoc. So if there's something you feel, as a community, you would like us to do a webinar on, please contact your individual contact and let them know. We will take this to the group. So thank you all very much.
Thank you.